Welcome to this video on bronchiolitis in children. I'm Dr. Sudath Abewikrama, a consultant pediatrician and senior lecturer in pediatrics. Our learning objectives are to define bronchiolitis, understand its pathophysiology, recognize its severity, outline evidence-based management, and know what not to do. Bronchiolitis is an acute viral infection of the lower respiratory tract, most common in infants under 2 years of age, particularly between 2 and 6 months. It's caused by inflammation of the bronchioles, often due to respiratory syncytial virus, or RSV. RSV is responsible for 75% of cases. Other viruses causing bronchiolitis include parainfluenza, influenza, adenovirus, and rhinovirus. Bronchiolitis is generally a self-limiting condition. In Sri Lanka, bronchiolitis occurs year-round, peaking during the rainy season. High risk factors include prematurity, congenital heart disease, and chronic lung disease due to limited cardiopulmonary reserve. The pathophysiology begins with the highly contagious RSV infecting the upper respiratory tract epithelium. It spreads to the lower respiratory tract, triggering extensive inflammation and increased mucus production, leading to edema in the airways. Clinical signs like wheezing indicate airflow limitation, while crackles are caused by secretions. Air trapping leads to hyperinflation, and a VQ mismatch results in hypoxia. The primary issue is the blockage of small airways in infants. Early clinical features include coryza and cough, progressing to mild fever, tachypnea, chest recession, wheeze and crackles, poor feeding, and potentially apnea in young infants. Diagnosis is purely clinical. Bronchiolitis should be considered if an infant has a URTI followed by an LRTI with respiratory distress, diffuse crackles, or wheezing. Routine investigations like blood tests or chest x-rays are not needed for diagnosis. Severity is assessed by evaluating feeding, work of breathing, oxygen saturation, and apnea. Severe cases are indicated by hypoxia, tachypnea over 50 per minute, or exhaustion and apnea in infants younger than 2 months. Investigations like CXR and blood tests are only necessary if there is unexpected deterioration with clinical signs like consolidation or pneumothorax, or if blood work is needed due to poor feeding or suspected co-infection. The core management of bronchiolitis is supportive care, focusing on oxygen, feeding and hydration, and continuous monitoring. Oxygen therapy starts with supplemental low-flow oxygen to maintain saturation between 90 to 92%. If that is insufficient, high-flow nasal cannula therapy is used. CPAP is reserved for impending respiratory failure, requiring immediate PICU contact. Enteral feeding, oral or via NG/OG tube, is the first choice. IV fluids are reserved for when enteral feeding is not possible. Be cautious with fluids in severe respiratory distress, as associated conditions may require fluid restriction. Monitoring includes periodic or continuous pulse oximetry, respiratory rate, use of accessory muscles, temperature, intake, and urine output. Apnea monitors may be used for high-risk children, such as preterm babies. Safe discharge from the ward requires the infant to be clinically stable, maintaining saturation above 92 to 94%, and having adequate oral intake to maintain good urine output. Parents should be warned that the cough may persist for 2 to 4 weeks. Prevention focuses on strict hand hygiene, avoiding contact with unwell individuals, maintaining a smoke-free environment, and breastfeeding. RSV spreads through droplets and direct contact, like kissing or handling. Avoid prenatal and postnatal exposure to smoke. Routine management of bronchiolitis does not include salbutamol, ipratropium, adrenaline, or steroids, as clinical evidence is weak or against their use. Antibiotics, antivirals, hypertonic saline nebulizers, and routine investigations are also not generally indicated.